Hi, everyone. Thank you for joining us for the CCSP monthly call for October. As you know, I'm Elsa Weltzine, Program Coordinator for CCSP, and it's great to see over 20 folks on today. So we'd love to see who's joining us. So if you could put your name and organization in the chat, as we always do. Plus this month, I was wondering what your favorite fall activity is to get us into the fall spirit. I finally was able to get up to the mountains last weekend to see some leaves before they fall off the trees. So I'd love to hear what everyone else has been doing for fall as well. And today, our main focus for the meeting will be, we're joined by a couple of members of the Denver Health GI team who will be sharing their experience with going through the CCSP planning process, sustainability planning process. And I'll introduce them in just a few minutes, but as we get started and everyone's getting settled, I also just wanted to share a couple of updates. So first, Andy is unable to join us today. She needed to get a small but unexpected medical procedure, and she should be back to work hopefully by tomorrow. But if you have any questions that come up over the next day or two, please just email me, or if you're emailing Andy, CC me as well. And then also, we have now already hit the end of the first quarter. So the end of September was the end of the first quarter. So please submit all of your evaluation data for colorectal cancer screening, as well as if you're involved in the lung and family history projects for everything from July through September by this Friday, October 9th, because the 10th is a Saturday. And please also submit your invoices for navigation services by Friday if possible to Barbara Johnson. So her email is barbara.p.johnson@cuanschutz.edu. And I'll put the link for the evaluation report and her email in the follow-up as well. But if you're unable to submit any data or invoices by this Friday, please just email me, let me know how many patients you're expecting to report for. Because it's the end of the quarter, we need this information for our quarterly reports. And also it's just really helpful for knowing where we're at with screening and allocation use so far. And I also like to remind everyone that we have barrier reduction funds available still. Because Lori has retired, please just email those requests to Andy and myself for prior approval, and we can get you approved, let you know the process for submitting those. And as a reminder, we can reimburse the clinic, but not patients directly. So taking a look at the chat real quick, welcome. See a lot of representation from all across the state. Our partners at Melissa Memorial in the Northeast, Marillac Health down in Grand Junction, Peak Vista in the Colorado Springs area, some of our partners here in Denver with Brunner Caritas, and Heather, love to see that you enjoy those pumpkin patches. So again, would love to hear what everyone's doing for fall as well. But I am now going to turn it over to Michael Cowan and Diogo Barbosa from the Denver Health GI Lab. They have really been champions for navigation, colorectal cancer screening, and CCSP at Denver Health for a number of years. And so they're gonna share about their experience with the CCSP sustainability planning process and how they've applied the framework to make the case for sustained funding of the navigator role at the Denver Health GI Lab. So I'll turn it over to Michael and Diogo to introduce themselves, but just like to highlight how much of Denver Health has been champions for this work and advocating for access for access to care for their patient population. So Michael and Diogo, would you like to introduce and take it away?
Yeah, sure. Hi, I'm Michael Cowan. I am the operations manager here at Denver Health in the GI lab, and I have worked at Denver Health for about 12 years, but have been in the GI lab for 2 years in about 1 week. So, and go ahead, Diogo.
Hi, this is Diogo. I'm a patient navigator here at Denver Health since 2016 at the GI lab. And I'm in Denver Health for now 8 years, since 2012. I work at Denver Health. I started as CHA, and then I moved to a patient navigator 6 years ago.
Yeah. And so this is our presentation that we put together for this group, just talking about the gastroenterology navigation sustainability planning at the GI lab at Denver Health. And we also wanted to just note that Dr. Levine, who is our former chief and pioneer of this program and really the biggest advocate we know, he worked with this on us, and he actually passed away on Friday. So he is in our thoughts as we discuss this, because he was one of our biggest champions for getting sustainability for this position.
Yep.
So I'm just going to quick go over the overview of slides that we're going to talk about, things we're going to talk about. What we really want to come away with is just kind of discussing just the time commitment that it took to pull all of this information together, and just how important it is. And I'm blanking, I don't know why. I'm not really great at presenting. Oh, but we also want your feedback on if what we're presenting isn't really speaking to you, or you think that we can visualize it in a different way, because we will have to go to our finance business partners and our directors to present this for a case for an expansion. So we really are looking for feedback at the end of this, or even during, but I will get started. So the overview of what we're going to talk about is just the timeline of the relationship with CCSP and DH, the scope of work of a navigator, the focus of the navigation here, specifically at Denver Health, and then documentation and collection methods, pre-planning of the business case, the extraction of the data, the outcome and effectiveness analysis. I forgot to put my finance bullet point in there, but I'm going to talk about finances, and then where are we now and what have we learned through this process. And Diogo's going to start with the first couple of slides.
Yeah, so we put a little bit timeline here, talking about the relationship between CCSP and Denver Health. And as far as, everything that I researched, CCSP actually came along with Denver Health 2006 to help folks just with copays. Was just a few colonoscopies done in the middle of when a patient was symptomatic, so colonoscopy was very costly, still is. So CCSP was helping folks with copays. Then in 2014, after the ACA, screening became a paid procedure by insurance, so then we automatically increased the numbers of colonoscopies done in the hospital. So in 2014 was a navigation to colorectal screening program. And in 2015, I got hired to the department with a task of 30% of the existing referrals were not being done. Meaning that we had a chunk of patients at Denver Health that needed a procedure, and for some socioeconomic reason was not done. Also, when I got hired, they specifically asked for a Spanish-speaking navigator, so I could massive outreach to the Hispanic and Latinx community in Denver, which is still underserved and under-screened. So we stopped that project, helping this 30% of patients that we already have help them figure out why the procedure was not done. So working on that, 2018, CCSP changed the name for the cancer screening program. So we now are more active in outreaching for other screenings, not only colorectal cancer, which helps us, find other funds and other outlets to work. In 2019, after Michael started here at the GI, she did a job audit based on the number of allocations, the new patients that I was working for the past 4 years. We thought that I needed a job audit that was not done in the past 4 years. So that was done. Then in 2020, the end of 2019, we start collecting all the data from Epic. Because prior to that, we had no metrics, how to pretty much prove to the hospital that I was working. That's exactly how, at the end of the day, how they came to me and said, we have no documentation proving how many patients you work. And so we start really focusing on that. At the end of 2019, 2020, we were able to come up with a really large data with a lot of good information. And we start working with CCSP on this sustainability plan. So we actually have numbers to show, and how to collect that numbers at any time, any point. So now we are with this timeline waiting in 2021, the decision if we're going to have more money or not under the grant. So that's where we are right now, waiting. So at Denver Health, my scope of work here, what we came up with, what makes sense for us, based on our population, based on our schedule, based on our, even the where the building is based on Denver Health. So my first focus is the highest risk patients. So patients that have visit ER, patients that come directly from primary care with symptoms, patients that have missed several colonoscopies still showing up at the ER. So pretty much, money talks. So if somebody spends a lot of money with GI problems and they need a procedure, the navigation is most needed on that one because these patients are going somewhere else to get help, which is not helping. So then also my focus points here is the FIT positive patients, the patients that have come with PrEP. I'm not reading that slide, but it's okay.
Okay.
But I'm talking about that one. Oh, okay. 1 second.
Well, that's okay. I can just go this. We can go back.
Okay. So
No,
this is the navigation focus group. So I start talking about that one. So the FIT positive, it's one of my jobs to explain and educate someone once they came up with a result of a FIT positive. Also, all the symptomatic referral sent by primary care directly to me for help. These are my patients too. And colonoscopies that are higher risk patients that had cancer in the past, polyps in the past, poor PrEP in the past, and they need follow-up. So it has been 6 years now working here, and I have closed the loop already now. I have seen patients 3 times, and they needed 3 colonoscopies in 6 years. They needed 4 colonoscopies in 6 years. So these are my patients now. And here are all the barriers. When I came to Denver Health, Dr. Levine, first thing he told me was that I need to focus on PrEP because at Denver Health, to have a good screening program, we need to make sure that our patients come in with excellent PrEP. So we, pretty much have a margin of no mistakes most of the time. Dr. Levine has collected many polyps. He's one of the highest one of the highest polyp collector at the GI department all over Colorado. And he was very proud of that. And because of the preparation that he really focused on it. Also, I focus on transportation. One of the things that I asked when I came to this job in 2015, that I would have access to unlimited rides. And I don't mean about Medicaid ride, Medicare rides. I mean rides that I can schedule in 10 minutes from now. So I needed access to that instead of succeed on these barriers. Because a patient that has an appointment in 1 hour, we cannot rely on Medicaid or Medicare or whatever other rights has done in a week, have to schedule a week. So I said that would not work for us here because when someone is prepping, they need to come in. It's not tomorrow, it's today. So transportation is a big thing here, and we have unlimited. We came up with unlimited cab vouchers. The patient needs to come in now or, don't have a car. We always going to have that resource. That's one of the key points when I start working here. Also, I'm partnered with NEHCD. I'm responsible for their referral and tailor prep for those patients that have difficulty understand the instructions that we have. Also, in 2017, we got a grant to pay 21 language translators the 1-day and 2-day prep. So that way, we have access to preparation in specific languages because we have a really large refugee community here. And one of the focus, like I said before, is the Latinx community and also the LGBTQ community that it's pretty much one of the most underserved community in our community, specifically in Denver. So this is one of my focus points working here at the GI Lab.
So when I started, my question was, how and where are you documenting all of your information on all these patients that you're navigating? And then he opened an Excel spreadsheet, and I was like, is this it? And then he's like, yep. And I'm like, I hope you're saving that in a very, very important place. We began a relationship and going down a road of how can we document this in a place or extract documentation from Epic and other places to say, okay, where else other than this gorgeous spreadsheet can we say how many times have you touched a patient or commented on a patient or anything. So just to give you just a smattering of all the places that he documents in 3 different roles in Epic. I think he's a scheduler, a navigator, and a GI tech. Because as anyone who uses Epic knows that not everyone can see the same thing and pull the same data from the same job role. So he has to use multiple roles to comment for the same patient based on what it is that he's doing. So obviously that Excel spreadsheet is one place, and then within Epic there are at least 6 places that he is documenting information that we are able to extract. And then there's an outside system that we use. It's a portal, but it's another place that collects information on how many touches he has with a patient. And then things that we didn't even in our data collection that we're going to present to you, that we did not extract. We did not look at emails. We did not look at text messages, and we are unable to quantify regular mail that he has used. So those are touches that cannot be counted. And when we get to the slides about like volumes, it's just impressive what he's doing without adding all that up. So this is a slide that really is saying this was our planning process in October with Elsa and Andy, Dr. Levine, and Diogo. We sat down and said, okay, so these are all the things that we need to get to be able to show Denver Health that this is really important, why, how much we're going to need, and moving forward. So this was our plan, our planning sheet. And we actually were pretty darn close in being on time. I don't want to like move my mouse at all, but I don't want to touch anything. But number 13 is really kind of the end of this because we started in quarter 4, like our first quarter was quarter 4. So quarter 3 is actually what just happened, and we have not yet presented to leadership. That's the only thing we haven't done yet, but that will tell you why here in a little bit. So moving on to the data extraction and effort. So after we figured out all the places that Diogo was documenting all of his information on touching the patients, emailing, phone calls, we basically were able to build reports that extracted that data, and then most of it was manually counted. So you can see, just as an example, and we don't have to go through each one of these, but to even get an idea of how many patients he touched as a baseline referral, not even if it was a PCP directly reaching out to him, but any person that he had contact with, we were able to go to one specific place within Epic called the questions box, where he, from the day he started documenting, he would put his initials in the box if he had talked to the patient. And I just thank the Lord that he did that, because it was so imperative, and just the volume was impressive. But I mean, just to extract that piece of information, I mean, took 10 hours. And then looking at all the touches in all the places combined, just ensuring like, okay, was this just a one-off? Like, we were able to look at the my chart messages and the database and the telephone encounters to say, yeah, he totally did this. Just to, I can't think of the word, but to validate. Yeah, so that took another 15 hours. So, you know, getting all of this information here took about 40 hours worth of work, just to pull it out and then analyze it. And actually, probably, I didn't even throw the analysis in there. The analysis was probably maybe another 5 hours, just to make it meaningful. And then basically this is his impact and the comparisons to other staff members here. And this is 47 months of data. And I think it should be noted that, you know, obviously there are vacations, some leave of absence in there. So it probably isn't even 47 months of like a productive. It's even less than that. Yeah. So just to give you some scope there. But so the amount of patients that he had contacted was almost 3,000 patients in those 47 months. And then of that, he has touched those 2,900 patients almost 6,000 times. Patients that were completed that he had touched, 2,400. Total procedures that those patients had was 2,700. The ones that he directly navigated, that someone said, I need you to help me with this, was a little over 2,000. And then just looking at metrics from non-Caucasian patients, 61% of his navigated patients are not white. Also lower income with our Medicaid DFAB CICP patients. Mostly male patients, which was really great, and a huge goal, which is great. And then just as a side note, of the patients that he helped to navigate, there were 3.1% of those patients needed some treatment post-procedure. And then on the bottom grid, to compare him as the navigator to the rest of my nursing staff. So my nursing staff generally touches a patient once. They call, they give them their prep information, making sure that they have everything that they need, and that's it. Diogo does that about twice per patient. Of the entire staff that I have, he completes more than what the rest of my average one staff member does. One staff member is expected or does about 9% of the work, and he does 13%. So just more production. Show rates, his patients show up a lot more than the other nursing staff who have called and aren't touching as much of the patients, and then his bowel prep success is much higher than theirs, as you can see. So if you look at the financial impact, and I had to do this with my finance business partner, and this did take quite a while, I'd say maybe 2 or 3 weeks of collection of actual patients, what our payer mix is, and then looking at our direct, indirect costs, and then coming out with a number. So if we're focusing on our 50-plus population, our contribution margin per patient at an average, putting all the payer mixes together, for a colon, it's $78, EGD, $113, and then for a FlexSig, funny enough, is $211. And so if we look at a volume allocation annually, you know, from an expectation standpoint, he is supposed to do 540. And when we look at the coverage of his salary, if we are going to go to finance and my leadership to say, not only everything that we've just said from a community need and a production standpoint, which we can clearly show based on those previous slides, what he will have to do more, he'll have to navigate more colons, but in addition to that, he'll also have to navigate EGDs and flexes to make up that difference with the salary. So 75%, you know, our hope is that 75% of his effort would still stay with colonoscopies, but in order to make sure that we make up the gap in his salary, he'll have to be doing other navigation. And the expectation would be about 265 more allocations or navigated procedures per year. But the nice thing about this is if for some reason, you know, if not for some reason, I think he should get a raise, and you know, maybe 675, you know, it's not possible, or he has to navigate more EGDs to make up that gap. We at least can mix up the cases, and we know where we're at from a finance standpoint if, you know, say we have to stop doing colonoscopies altogether for COVID. You know,
Yeah.
like maybe we start navigating other patients for EGD, urgent EGDs. But anyway, so that's what the financials looks like. And then what are we waiting for? I believe we're waiting for November to figure out, to hear from CCPD on whether we are going to continue getting funding for him. So once that happens in our budget cycle here at Denver Health, expansions were due last month, but because there is a possibility we might still get funding for him, I'm going to wait till the next cycle, which will be in April. But I have already told my leadership, they know all this information, I just haven't formally put it down on paper. So they are aware that this is coming if our funding ceases to exist. And lessons learned from our standpoint, from a documentation standpoint, just finding any way to minimize the manual extraction. Like if you can find a checkbox or anything you can do within whatever system you have is incredibly important. And then something else that we just found out that Epic can do for us is, you know, we have a depot of where all of our orders and referrals to our colonoscopies or any other procedure comes in for. We can make another depot for Diogo. So if a scheduler looks at it and said, oh, they're homeless or they need ride or they need something, they can actually click a button and that person, that patient, will go into a depot specifically for Diogo, which doesn't exist now, and we have 1,306 people in our depot, which makes it very difficult to navigate if you're looking in just a comment section of Diogo. That's literally what they write in the box. So this will be very helpful. Another thing, don't procrastinate. This took so much time to do. The extraction is 40 hours alone, not including working with your finance business partner to see the actuals of your payer mix and what's happening, and then analyzing. And then, you know, doing this, putting this presentation together, like trying to make this as meaningful as possible, and then you're going to have to go and vie for this position, you know, with your leadership. And then monthly, doing this, instead of doing this in 40 hours for a week, which I did do, it was really impressive, doing this monthly where it's like, okay, this is the volume of people he touched this month, that I would recommend. I haven't done that, but that's my recommendation since I did this back in April, May. And then lastly, again, start introducing just the idea of what your needs are with your finance business partner and your director early so they're not caught off guard. That would be my last suggestion. And we're done.
Thanks so much, Michael and Diogo. That was really helpful to really see all of the data you've been collecting for so long and that we've been working with you since the start of this grant program down on paper and really seeing it after all, figuring out how to collect all of it, all of the results, which just seem like a few small statistics, but really seeing how much effort that all took down on paper. So I thought that was really insightful. So I haven't seen any questions in the chat yet, but I would like to invite everyone who's on the call today to see if there's any thoughts, questions, comments about how Denver Health's sustainability plan from idea to actual application hit you? Do you think that this would show the value of navigation in your own organization? Have you done anything similar, even if your sustainability plan isn't focused on the funding stability piece? Has your organization undertaken any similar efforts? Would just love to see how this hit everyone. I'll give everyone a moment to type any thoughts in the chat. And then also, if you want to come off mute, reminder that on the bottom left, you can take yourself off mute, or if you're on the phone, *6 to come off mute. All right, well, while you're all thinking of questions, I'll start with a question for you all, Michael and Diogo. If there's other clinics or organizations who want to pursue a similar approach, how would you suggest they introduce this idea to leadership at their organization?
Well, I mean, I think you have to have some inkling of what your productivity is, right? Because I don't know an organization that you go to leadership and say, I really, really want this, and they'll just give it to you, which would be really great. So I think just having some sort of, you need to have some data initially when you're saying, hey, listen, this person is navigating this many patients, this is the amount of time, this is what my other staff is doing. It's really just, but we're also a data-driven organization, so the expectation is that you can't ask for anything unless you actually have proof that it works. So I think that speaks volumes, is just having data to support your need, and then why it's beneficial, you know, then to the community. And you know, Denver Health, our mission is to serve, you know, absolutely everyone, but really specifically focus on the underserved. But, you know, no margin, no mission. So, you know, we have to be honest about what our work will be. And that's why, you know, right now we wouldn't be able to sustain Diogo if he continued at his current volume and only doing colonoscopies. We wouldn't even be able to come close to meeting his salary based on our contribution margin. So.
Thank you for that. And I would also just ask, you've talked about this a little bit, but if for your own efforts in this and for other groups, what additional resources or support do you wish you had, or either that you got through the process or that you would have been helpful to enhance this even further?
I think having a consistent documentation would be helpful. Not that we can ask every organization to all have Epic and document the same way, but if there was some sort of, you know, like a smart sheet where you could, I can see something, CCSP can see, we can all see the same thing and all be collected in one time, that would be amazing. An analyst, gosh, I would love an analyst to help gather all of this data. Have my own Epic analyst actually probably would have been the most helpful. Yeah, I think just the analysis was just the most time consuming, and then just trying to find the information. If we can make this easy to find, I mean, that would have been half the work.
We've definitely heard from a few other clinics recently that they've gone through recent EHR changes or have adopted Azara, if they're a federally qualified health center, to help with some of their data management, but there's so many intricacies that people don't know whether you can collect a certain piece of information or not, that one of our webinars we're hoping to do this year related to sustainability planning will to bring someone in to speak about using Epic or Azara for navigation and cancer screening and how to best utilize those systems. So definitely agree that that's been a challenge, and there's really not a lot of literature out there either as it relates to cancer screening. So I know we've had a little bit of a quieter audience today, but I know that some of you have focused your sustainability planning efforts on the funding stability piece, while others have been more focused on enhancing your workflows, making sure you have the systems in place to capture evaluation data. So I'd like to open this up to beyond just the focus of Michael and Diogo's presentation on their sustainability planning efforts, to see just from those on the call today, if this sparked any thoughts or ideas for your own sustainability planning efforts, and if there's different questions or thoughts you have for your own peers on the call today as a CCSP clinic, as we're going into either the last year of CCSP sustainability funding, or as Michael mentioned, hopefully in November we will find out that we will hopefully, fingers crossed, have an extra year of funding through 2022. So would love to hear if anyone else has any thoughts or questions as related to sustainability planning, since that's the focus for the call today, but we can open it up more generally to sustainability planning. And I might call on a couple people if we don't get any volunteers. So Irma and Katie, I see that you're on from the Sunrise team, and the Sunrise team has really been focusing their sustainability planning efforts on increasing FIT and stool-based testing rates. So would love to hear how this hit you as you're thinking about your own sustainability plan and the things that you've been measuring. Does anyone, Irma and Katie or anyone else on the call, do you feel like Michael and Diogo's presentation and your own sustainability plans have really helped show the value of sustainability, and any examples you might have?
Okay, can you hear me okay? This is Katie.
Yes, Katie, hi.
Okay, hello. So I think, I mean, obviously like the work that Michael and Diogo have done, like you've done some extensive like documenting and things like that over the years, which I think is like awesome. I've been here at the clinic for like about 4 years. And I know that we're working on our sustainability planning and all of that, which is, I think, going okay, and maybe Irma can speak more to that. But yeah, I think that it would be, what I think would have been really awesome would have, like back before I was here when CCSP helped pay for colonoscopies and things like that. Like I know that was really helpful for a lot of our patients, and I think that's where we like run into a lot of issues now, is that we just have a lot of people who are like sliding fee, or who are on our CICP program who really just can't afford a colonoscopy. And so having that funding, I know was super helpful, and it would have been really awesome to see like back when we did have that, like if anyone had documented that, but I'm not sure, you know, before me and before Irma, I don't know if anybody like did document that kind of thing, but I know that that seems like something that would have been really great to have some data on. But anyway, but I know we are like trying to get more fit kits out and things like that, which is good. I don't know, Irma, did you have anything to add to that?
I agree. Before our time, we had some of that funding, and I know that we were able to help a lot of patients with that. And without that service, it's really, it's been one of our biggest barriers over in northern Colorado is to get these people in to get a colonoscopy. We did have one person assigned in our quality team to reach out to our patients for fit kits, and as far as I know, she's reached out to like 400 people, and she's received about 250 kits back, which is pretty good, very good.
Excellent. Yeah, go ahead.
But definitely, it would have been nice to have that data from when we were doing colonoscopies in-house. I mean, it's a big need here. Not to say that Katie and her expertise in patient navigation has been very important right now as well.
And I just like to share that, so CCSP, we have shared this with Denver Health and a few other clinics. We do have the ability to pull your data for the years of the program since it started for your individual clinic. Still the aggregate data that was reported to the program and as it has changed over the different services that CCSP has offered, including when we were paying for colonoscopies, and the metrics have shifted a bit over time as well. But CCSP is able to pull your individual clinic data for the demographics and outcomes of patients navigated. And that is something that we shared with Michael and Diogo as they were putting together their case. And so that is a great starting point for data. And so I can let Michael and Diogo speak to this more, but I think they started with the data that we provided from what was available from all the years of CCSP, and then they added, looked at it and saw what was not captured, such as touches with patients, and then figured out what they would need to track to build up their case further and how they could possibly track that. So Michael and Diogo, I don't know if you have anything else to add about use of the CCSP data compared to the other data that you started tracking for this business case.
So actually the only data that I used was the data that Diogo had collected. Yeah. So whatever he had sent to you, I just asked him for it, and that's basically what I used.
Okay, great.
We'll just start.
Yeah, absolutely. So anyone else on the call, we're happy if you to send any of your CCSP specific data from all the years of the program and can pinpoint when the when CCSP stopped paying for colonoscopies directly around 2014, 2015. So if that's something you'd like to look at, we're happy to send the data we have available from the program evaluation reporting and work with your clinic and using the expertise from clinics such as Denver Health to capture some additional pieces of information if that would be helpful. And before I came on to CCSP, Nicole, who was in my role previously, had worked with a couple of clinics, including High Plains and I think Marillac, or it was Sunrise, to start to think about what data would be needed to put together a business case. And so we have a couple of those worksheets as well. And since a lot of clinic systems haven't been focused on the funding stability piece specifically for their sustainability plan, have not shared those with everyone, but I also just put in the chat that CCSP has recently created a supplemental sustainability planning website, in addition to our regular Google site that can be accessed on the resource links page of the CCSP website. And that contains all of the information about the PNSAT assessment that you took to look at capacity for sustainability, the action planning tools, but also some of those worksheets with ideas about metrics and how to collect certain metrics to build a case for sustainability, including the value of improved outcomes from navigation, as well as some of those financial pieces similar to what Michael and Diogo shared about today. And so I'd invite everyone to check that out because CCSP is continuing to be here to support you all with your sustainability planning efforts this year and hopefully for one more year beyond if we get our extension year of funding. However, we want to have some of these resources live in perpetuity. So just wanted to share that it's accessible through the CCSP website and also is just a good resource hub. And if there are any additional resources that have been helpful as you've been going through your own sustainability planning processes that we could include for that, we'd love to add that to the site as well. So would love to give anyone else on the call any more opportunities to share any ideas, feedback around sustainability planning, any lingering questions you have for Michael and Diogo. All right. Well, thank you so much for sharing today, Michael and Diogo, about your efforts in the sustainability planning process. I know it has been quite a lot of work, as you illustrated through the 40 hours that you all put into this, but I'm very excited to see how this continues to play out, and we're here to support, and we'll keep everyone tuned as to whether CCSP is getting an extension year. And as I mentioned before, we should know more in November. And I can't say too much else about our additional efforts to explore opportunities for additional funding. However, I will just let everyone know that we are continuing to explore some options to continue to fund the efforts that CCSP has helped with for so long beyond the life of this grant, and looking at assisting with direct medical services for those in need, because as we've heard from you all during this grant cycle, that does seem to be the largest continued barrier to increasing screening rates and getting patients access to colonoscopy and other screening services, as ACA expansion has now been in place for many years. So CCSP will keep you updated as we have more information about our efforts to secure funding. But those are the main pieces around sustainability we have today. Before we hop off the call, I just wanted to also highlight a couple of events coming up. And please feel free to follow up with me or Michael or Diogo if you have any lingering thoughts that you think of after we get off the call today. But just two events that are coming up as we hop off the call today. So on October 21st, CCSP is partnering with the Cancer Coalition, the American Cancer Society here in Colorado, and WWC and CPED programs to host another series of peer sharing calls. And these will start monthly on October 21st and run from 11:30 to 12:30. And the first one will focus on flu season, COVID-19, and getting patients into the clinic for screening and other services that they need. And so for those of you that were on our first peer sharing call over the summer that was focused on relaunching screening efforts in the COVID-19 era, this one will only have one case study going forward, and then we'll really leave the majority of the time to focus on open-end discussion. And it really is just an opportunity to connect with your peers. This is not only geared towards navigators, but we're really encouraging navigators and other people involved in the clinic to attend these calls. And then there also will be the Colorado Cancer Coalition Annual Symposium on November 5th and 6th. And so this year the symposium is virtual, completely free, and will be focused on COVID-19 and impacts for cancer, and impacts on cancer across the whole continuum from prevention, screening, treatment, and survivorship. And then there'll also be opportunity to network virtually and then learn more about how to get involved with the Cancer Coalition. And so I know some of you have had the opportunity to attend the symposium in recent years and could probably attest to a great opportunity to meet people all over the state in many different aspects of cancer care across the whole spectrum, and that it provides some actionable ideas to take back to your work. So I'll send the registration links for both of those in the follow-up. And that's all I had for today. So another huge thanks to Michael and Diogo for being on today. And I hope this was helpful for spurring people's ideas around sustainability planning, even if your own sustainability plan looks a little bit differently. We'll be continuing to check in with all clinics at least once a quarter about your sustainability planning efforts. And we will have some more opportunities for peer sharing, but really want to just get people thinking about how to enhance their own efforts and how we can support you all. So have a great rest of your Tuesday, everyone, and we'll see you next month. Bye-bye.